So you're training to be a radiation therapy technologist, right? You're learning all about how to deliver radiation with this incredible pinpoint precision. But have you ever stopped to think about what really happens when those photons hit the patient? Well, in this explainer, we're going to go on that exact journey, from a single photon to the patient on the table, to really get the why behind everything you do in the clinic.
Okay, let's just dive right in with this question, because it gets to the absolute heart of it. We are talking about something that happens so fast, it's almost impossible to imagine. I mean, a trillionth of a second. What happens in that first tiny fraction of time is what kicks off the entire chain reaction, a reaction that ultimately decides if the treatments you'll be giving are successful or not.
So to get our heads around this, we're going to break it down into 5 parts. First, we'll look at that initial moment of impact. Then, we'll zoom right in on the main target, DNA. After that, we'll see how a cell makes a life or death choice and how all those tiny choices add up to the clinical effects you'll actually see. And finally, we'll see how all this science shapes the safety rules you'll live by every single day.
All right, first up, radiation's first contact. You see, before we can even begin to talk about biology, we have to talk about chemistry. Because when that photon zips into the body, its first collision isn't with DNA, it's with something way more common inside every cell.
And that something is water. This process is called indirect action, and it's a huge deal. Just think about it. Your cells are like 80% water. So statistically, a photon is way more likely to hit a water molecule than anything else. So the damage isn't direct. It's more like a ricochet. This indirect hit is what starts almost everything else, especially with the kinds of X-rays we use in therapy.
So how does this work? Well, it's a super fast 4-step process. A photon slams into a water molecule and knocks an electron clean off. Now you've got this unstable, charged water ion that immediately falls apart. And what's left is something called a hydroxyl radical. The best way to think of this thing? It's like a tiny molecular bully. It's super reactive, totally unstable, and now it's just roaming around inside the cell, looking to cause some serious trouble.
So now we've got this molecular bully on the loose. What's it going to attack? Well, these free radicals can damage all sorts of things. But for radiation therapy to actually work, there's one target that is more important than all the others. And that is, you guessed it, DNA.
But, not all DNA damage is a catastrophe. Sometimes the radical just causes a little base damage, which is kind of like a typo in a long book. Or it could cause a single strand break. Think of that like breaking one tooth on a zipper. The cell can usually patch these things up, no problem. But there's a third type of damage, and this is the one we're really aiming for.
This is the big one, the double strand break, or DSB. This is the most lethal injury radiation can cause. It's not a typo, it's not a broken zipper, it is like snapping a ladder clean in half. The cell has now lost its structural integrity, its blueprint. It's almost impossible for it to divide properly after this. This is the kill shot we're trying to deliver to cancer cells. Now, our healthy cells are pretty tough. They have repair crews ready to go. The first one is called non-homologous end joining. Think of this as the fast and dirty emergency crew. They rush in, jam the 2 broken ends back together, but they often make mistakes. The other option is homologous recombination. This is the master craftsman. It's slow, it's methodical, and it uses the undamaged sister strand as a perfect template to make a flawless repair. And here's the kicker. A lot of cancer cells have really bad repair systems, and that's a weakness we can exploit.
Okay, so that leads us right into our next big question, the cell's life or death choice. What happens when that double-strand break is just too much to handle? When the repair crews give up, the cell has a critical decision to make.
Basically, a damaged cell has 3 ways this can go. 1, it somehow manages to repair the damage and gets to live another day. 2, it recognizes things are hopeless and triggers a clean, programmed self-destruct sequence called apoptosis. Or 3, it can just ignore all the warning signs and try to divide anyway, which leads to, well, a complete and utter disaster.
Let's look at those last 2 options. On the left, apoptosis. This is a quiet, polite death. The cell just neatly packs itself up to be cleaned away. You see this a lot in blood cells. But on the right, that's our main event, mitotic catastrophe. This is reproductive death. The cell, with all its broken DNA, tries to divide and just tears itself apart in the process. This messy, catastrophic failure is the #1 way we kill solid tumors with radiation. It's what we want to happen.
So that brings up a really important question, one that impacts your job every day.
If radiation is so good at causing this catastrophic damage, why do we bother giving treatments in these small daily doses for weeks on end? Why not just one giant blast? Why don't all the cells just die at once?
The answer is right here, in this classic cell survival curve. Look at the very beginning of the curve, at low doses. See how it doesn't just drop straight down? It has a little shoulder. That shoulder is everything. It represents the cell's amazing ability to repair what we call sublethal damage. Basically, nicks and cuts that aren't enough to kill it outright. And this ability to repair is the entire reason we use fractionation in the clinic. By splitting the dose up, we give our healthy, normal tissues time to fix themselves between treatments. The cancer cells, with their shoddy repair crews, they can't keep up. The damage just builds and builds until it's overwhelming. That's how we win.
All right, let's zoom out a bit. We've been super focused on what's happening inside a single cell. But what does this look like on a larger scale? How do these tiny events, happening billions of times, turn into the real-world side effects you're going to see in your patients?
And here's the rule of thumb. It's actually pretty simple. How fast you see a side effect depends entirely on how fast the cells in that tissue divide. So, tissues that turn over really quickly, like your skin, the lining of your mouth, your bone marrow, they're going to show effects within days or weeks. Those are your acute effects. But tissues where cells barely divide at all, like your lungs or your kidneys, the damage might not show up for months or even years. Those are the late effects we always have to watch out for.
And a perfect example of an acutely responding tissue is bone marrow. When we're talking about a whole-body exposure, bone marrow is the most sensitive system in the entire body. And why is that? Because its stem cells, the little factories that make all of our blood, are constantly dividing, which makes them incredibly vulnerable to radiation damage. Understanding this is key to managing a patient's blood counts during their treatment.
All right, we're at our final stop on this journey, protection and dose limits. All of this biology we've talked about, from the free radicals to the tissue responses, it's not just academic. It's the scientific bedrock for all the rules and regulations that are designed to keep you and the public safe.
Now, at the low doses we worry about in radiation protection, the main concern is what we call stochastic effects. And this is all about probability. It means that as your dose goes up, your chance of something bad happening, like getting cancer, also goes up. It's like buying lottery tickets. The more tickets you buy, the higher your chance of winning, but the prize money itself doesn't get bigger. And because it's a game of chance, we have to assume there's no safe dose, no threshold where the risk suddenly drops to zero. So to manage that risk, we have annual dose limits. The whole goal is just to keep that probability of harm at a level we consider acceptable. So for you, an occupational worker, the limit is 20 millisieverts per year. But look at the limit for the general public. It's way, way stricter. Only 1 millisievert per year above what they'd normally get from background radiation.
Let's just pause on that number for a second. 1 millisievert. It sounds tiny, right? And it is. It's set that low to be incredibly cautious. But what does a number that small even mean in the real world?
Well, here's some perspective for you. A single CT scan of the abdomen can give a patient 5, maybe even 10 times that entire annual public limit in one go. Now, that doesn't mean CTs are dangerous. They are amazing life-saving tools. But what it does mean is that every single exposure to radiation has to be justified. The medical benefit has to clearly outweigh the risk. And that principle, justification, is a cornerstone of your job. So, let's tie this all together. What a journey, right? It all starts with one photon creating one molecular bully. That bully then causes a double-strand break, the kill shot, in a cancer cell's DNA. The cell tries to divide, fails catastrophically, and dies. And that process, repeated billions of times, is what kills a tumor and also causes side effects, which gives us the very foundation for our radiation safety rules. From photon to